I have a low bandwidth, so I'm not switching on my video. So I hope you enjoyed the first session. So this is now today we will discuss a few things which we usually come across, and we always find it difficult, and we don't know how to manage in such situation. So, Dr. Biju Raghavan, whom I introduced you in the last session, is heading the Pain and Palliative Medicine Department at Rajagiri Hospital, Alava. And he has done his diploma in Pain and Palliative Medicine from Amrita Institute of Medical Sciences, and has been in the field of palliative care for more than 16, 17 years. And um, he will be discussing how to communicate bad news and how to manage collusion, and if possible he will touch upon other difficult situation. So welcome Biju, and it's over to you.
Thank you, Sunil, for the kind introduction. Rajlashmi, without much ado, we will proceed with today's session. Can you start sharing the screen, please? Welcome, everybody, for the second part of the communication skills session. In the last session, last week, at the same time, we had talked about the basics of communication, a little bit of body language, some do's and don'ts, etc. And now today we are going to cover how to communicate bad news. These are essentially very difficult uh, communication skills. Also, how to manage collusion. Uh, that is when patients' families come to us and says, "Please don't discuss this with the patient." So that is collusion. So how to deal with it? And we'll, as Sunil said, if possible, with time permitting, we'll also try to cover how to deal with an angry person in the clinic, in the medical clinical setting. So shall we start with the next slide? Can we have the next slide, please?
So 1 second, we are having some technical glitches here.
Okay.
Yes, sir, you can continue.
All right. So when we talk about communicating bad news, generally all over the world, people have either of these two models that they follow. Either they tell the bad news to the patient, which is called a full disclosure model. That is, you tell the whole details to the patient, or like it is usually the case in our environment in India and most of the Asian countries, we usually do not tell it to the patient, and that would be the non-disclosure model. So these are the usual two models in many of the European countries, America, Australia, most of the developed countries. They many times follow full disclosure model. That is, they tell to the patient. Now, the reason behind that is that in those countries, the patient's autonomy is held to be sacred. The patient's autonomy is very important. So you can talk to the family only with the permission of the patient. Whereas in our country and most of the Oriental countries, the Asian countries, the autonomy of the patient is below the family's uh, will, and as a result, most of us we will uh, talk to the patient only if the family allows it. That is the basic difference why these two kinds of practices are followed. Can we have the next slide? However, when it comes to good communication skills, we have to remember these two facts. One is the patient has the right to know, and the second part is the patient has the right not to know. What that means is we have to cater to the individual decision or the likes and dislikes of the individual, that is the patient, whether the patient wants to know or whether the patient does not want to know. And we also have to consider that if the patient wants to know, how much does the patient want to know? Does he want only 25% of the information? Does the patient want only 50% of the information? Does the patient want 81% of the information or 100% of the information? Next slide. So this is the dilemma. What do we do? The usual practice is either you tell it to the patient or you do not tell it to the patient. Family, of course, we we inform the family, but here we are talking about communicating bad news to the patient. Next slide. So, keeping that two principles, the patient has the right to know, and the patient also has the right not to know. If the patient does not want to know, we should not impose the information. So, this is a model. This is the individualized disclosure model that we have to learn how to practice. Because in an individualized disclosure model, we first figure out whether the patient wants to know or not. If the patient does not want to know, we will not impose the information. If the patient wants to know, then we will try to find out how much and give information what is optimum to what the patient wants. Not less, not more, optimum to what the patient wants. So this is what we have to learn today in how to communicate bad news. That is the challenge in front of us. Next slide. So before we get on to that, we should understand who should communicate bad news. Many a times, people think it has to be the doctor. Sometimes it need not be the doctor. It could be the person the patient trusts the most. And for that, we as medical practitioners should make an effort to win the trust of the patient. And that's where the communication skills comes in, which we talked about in the previous session last week. So if you are not the person the patient trusts the most, then whatever you may say, the patient may not believe you. It's very important that the bad news is communicated by the person who is most trusted by the patient. And that person could be the patient's friend or a family member, or maybe the nurse who regularly looks after the patient, but it could also be you. The second most important thing is that the person who communicates bad news should have information. Now, information does not mean medical jargon. Information in a simple language that the person can understand. And this is sometimes a big handicap for doctors because doctors are many a times not able to convey complex medical issues into simple, understandable language. And that is a big handicap for many of the doctors. So it is not necessary that the person who conveys the information should know medical jargon. It is very important that the person should have clear understanding of the medical condition and what is possible and what is not possible. And if you are the medical care provider for this person, it is as a doctor or a nurse, it is very important that you learn how to convey this kind of information without bringing in medical jargon. And the third important aspect is the skill to communicate bad news, the skill to recognize whether the patient wants to know or does not want to know, and then also to find out how much the patient want to know and to serve the quantity of information optimum to the patient if the patient wants to know. So that's the skill. So the combination of trust, information, and the skill is what goes into good communication. sharing of information of bad news. Next slide. So why is it important to communicate bad news? Let's say somebody asks you, here is this gentleman, 70 years old, advanced malignancy. What purpose would there be in that person knowing? Let him not know. Let the person be in peace. Let the person, you know, not unnecessarily be burdened by this bad news. So we have to consider a couple of things. One is there's a possibility that there are many things not finished in a person's life when a person has been diagnosed with an incurable progressive disease. There may be issues related to will, property, money, debts, or loans taken. There may be issues of relationships where the person may have had a bad relationship with somebody, and the person may want to mend that relationship, maybe ask forgiveness, or to be or to give for or to forgive the person for whatever led to that friction in relationship. The person may have desires of visiting a certain place, to experience something, to meet somebody. So there can be many things which we can think of that we want to finish. Somebody may call it a bucket list. Somebody may call it tying up the loose ends before you go. But if you have an incurable progressive disease and you're terminally ill, at least you have a chance to finish the business of life before you go. This cannot happen if you die suddenly with a heart attack or in an accident, but you definitely have a chance to finish whatever you need to finish when dealing with a progressive terminal illness. Now, all these things can be possible only if you have reasonable physical and mental health. If the person in the gasping stage or in a delirious stage or terminal delirium, at that point of time, communicating bad news serves no purpose. So it is the communicating of bad news should be done as early as possible. Another issue to consider is hospital hopping and doctor shopping. Because patient has not been told what's the diagnosis and the prognosis. The family understands, the patient does not understand, or maybe the patient and the spouse have not been told, the children understand. In this kind of situation, what happens is the patient does not understand what is happening to him or her and expects to get back to normal life before the disease was discovered. The rest of the family understands that that is not possible. The patient does not understand. And as a result, the patient's expectation becomes unrealistic because they do not match with the patient's reality. And because of this mismatch in expectation and reality, the patient loses all trust and faith in whatever treatment you are giving. And after some time may decide that I want to go some other place, and demands, he or she may demand to be taken to the next hospital, to the next city, or to the next type of healthcare, from modern medicine to Ayurveda, or from Ayurveda to Unani, whatever. So this hospital hopping and doctor shopping, not only is it futile, it drains away the family's finances and other resources. They end up taking loans, selling off their house, children's education goes out of the window, and the patient dies and the family is on the street. So this happens because timely communication of bad news never happened. And we healthcare professionals contribute to a lot of poverty in our country because of not being able to communicate that what is happening is futile. So don't go for hospital hopping and doctor shopping. Just saying don't go does not solve the problem. You have to make them understand why you are saying that. And then the third part is barrier between the patient and family. The patient doesn't understand what's going on. The family understands what's going on. The family sometimes gets overwhelmed and they go to the next room and cry, or they go to the neighbor's house and cry. The patient doesn't understand what is going on, but the patient can feel the changes in his or her body. The patient can feel that some things are being hidden from him or her, and then the patient feels isolated, alone. So all of these things will create a barrier between the patient and the family. And this is the time when the patient and the family, the relationship should have been the most strong, where the family supports the patient. But most of the time, in this phase, we see families doing a drama. They enact a drama as if everything is okay inside, in the house, in front of the patient. But then out of away from the patient, they uh, are always crying, and in a very emotionally bad way. So all of this thing is a futile exercise. Whereas we should, if the issue was out in the open, the patient knew what was going on. There would have been a time to hug and cry. There would have been a time to say goodbye. There would have been a time to say, I love you. None of those will ever happen because there is a barrier. Because the barrier was created by not communicating bad news. And the last part is in palliative care, we talk about total care. We talk about providing physical comfort by taking care of pain and other symptoms. We talk about providing emotional comfort, relief of anxiety, depression, anger, etc. We talk about social comfort, harmonizing the relationship within the household and outside the household. And we talk about providing palliation of existential distress. So we, with this without communicating bad news, at best we can provide a little bit of physical comfort. We will never be able to relieve the anxiety or the frustration of what is going on. We will not be able to sort out the friction within the family because of these issues. So it's very important that for total care, there has to be an honest and transparent relationship between us, the patient, and the family. And not communicating bad news does not help. And this is the reason why it is important to communicate bad news. It's a huge responsibility on us to facilitate discussions and to carry it forward. Next slide, please. So this is the spikes protocol. uh, Everybody talks about spikes protocol, and it is a well-tested method. Basically, what it says, you have to set up the interview. That is, you have to create the environment. Then you have to find the perception, that you have to find out what does the patient understand about what is going on as far as the disease is concerned. Then you have to invite the patient for having a discussion on this. And then you have to share the knowledge honestly. If the patient accepts invitation, then you share the knowledge honestly. Then you have to address the emotional outcome of that. And then you plan what needs to be done. And then you summarize, and that is exact. This is what spikes is. Very simple, but but actually in practice, it isn't as you might expect. Next slide, please. So when I teach communication, I teach communicating bad news as a procedure, as a surgical procedure, and it can be put it into the elective category, elective surgical procedure. Similarly, communicating bad news is a elective communication procedure. So this is procedure of communicating bad news. Next slide. So what are the pre-procedure preparation? Just like pre-anesthetic checkup, we have to do a pre-procedure preparation. That is, read all the related documents. Even if you are the regular patient of the patient, regular doctor of the patient, still go through the documents prior to the procedure, and then allot a dedicated time, just like a surgeon will allot a dedicated time to do a cholecystectomy, uh, because you can't do it in between other things. Similarly, communicating bad news is a very important elective communicating procedure, and hence allot a dedicated time for it. In my personal practice, I usually keep it in the later part of the evening, because by the time all my work related to IP, OP, everything is over, and then probably this would be the one of the last things I'll be doing for the day, because by the time the OP area would be quiet, most of the rush would be gone. It's a quiet environment, and there'll be not much rush. The right environment for me to communicate bad news to the patient, with or without the family. So the next part is set the, as I just mentioned about, set the environment for this. Next slide. When we start the interview, if you if you already know the history of the patient, that is okay. Otherwise, if it is your first meeting or one of the early meetings, just go through the patient's history. Start taking the patient's history. We have talked about history taking in the last week's session. Just remember that, and get the patient's insight and concern. So you have to ask. So what do you think is happening to you? What do you know? What have you been told by the doctors? What have you understood from all these tests and scans that you have undergone? So it's important to understand what the patient insight is. And you may realize that the patient probably understands a lot of things which are right, but may not understand a few things and may have a wrong perception. Or it is also possible the patient does not understand most of the things that is going on, but understands a few things. It is possible that the patient understands a few things and does not understand a few things. As possible that what he understands is absolutely bang on right, or it is totally different from reality. So that is the importance of finding the insight to understand what the patient understands. And once that is clear, you will understand that patient understands a few things which are right, but understands a few things which are uh, wrong or inadequately informed. Once you have understood this, you also need to understand what the patient's concerns are. What is the person most worried about? What is the person most afraid of? What's the most thing that makes the person sad? What makes the person angry? Many times I have found that when patients are very sick, they lose appetite and the family tries to feed them, and that makes them very angry. The forcing of food makes many patients very angry. So it's just a matter of inquiring, and you will find so many concerns that they have. So once all of that thing is there, then you have to explore whether the patient wants to know, right? That is how you are going to give an invitation for talk. So how do you ask if the patient wants to know? We'll say, so do you want to know more about your disease? And if the patient says yes, do not start talking about the disease yet. You have to first give a warning shot. What is the purpose of the warning shot? It tells the patient that something serious is going to be discussed. And that gives the patient an opportunity to decide whether the patient wants to know or does not want to. If the patient does not want to know, the person, after getting the warning shot, may make some excuses like, okay, you give me the medicines, I'll come after 2 weeks. Or the patient may say, oh, you tell it to my children, tell it to my daughter, tell it to my son, etc., etc. Or the person may directly tell you, no, I don't want to know, if it is something serious. On the other hand, after giving the warning shot, if the person looks into your eyes, makes eye contact and says, "Yes, I want to know," then it is very clear that here is a person who really wants to know, even if it is something serious. So, how can you frame a warning shot? Next slide. So, this is a good example of a warning shot. If it is something serious, would you still want to know? If it is something serious, would you still want to know? And it is important that you convert this into your language of communication. If you speak Hindi, maybe you can say, अगर बात कुछ सीरियस है तो भी फिर तो भी आप जानना चाहेंगे. अगर बात कुछ सीरियस है तो भी आप जानना चाहेंगे. क्या फिर भी आप जानना चाहेंगे? In Malayalam, I would say കാര്യങ്ങൾ ഇത്തിരി സീരിയസ് ആണെങ്കിലും അറിയണമെന്നുണ്ടോ? കാര്യം ഇത്തിരി സീരിയസ് ആണെങ്കിലും അറിയണമെന്നുണ്ടോ? So it is basically a translation from this what you see on the screen in English. If it is something serious, would you still want to know? Remember, the precision of what you say is very important when it comes to warning shot, because you just cannot afford for the message to go wrong. The message has to be exactly this. If it is something serious, would you still want to know? And then you convert it into the language of your communication. Next slide, please. Post warning shot, there will be a change of atmosphere. It will become very serious. And then the patient will get a chance to consider the decision whether he or she wants to proceed or not. And if the patient looks into your eyes and says, "Yes, I want to know," then you tell the patient's story to the patient from the beginning, like a story. That is what is called as a narrative approach. You tell the story of the patient to the patient from the beginning. Next slide. So this is what I was talking about. So when you are telling the story of the patient to the patient from the beginning, you know you have explored the insight of the patient. So you know there are a lot of gaps in the patient's understanding. You know that there are things that the patient understands, which is correct, and there are a lot of things the patient does not understand. And your job is to fill in the blanks. When the story moves to the area where the patient does not understand, you fill in with a chunk of information. And once the patient has that small bit of information, observe the patient, observe the body language of the patient. If the patient continues to make eye contact, continue the story. If the patient breaks eye contact, put a pause to the story, because the patient may be thinking about this new information. And if the patient wants more information, the patient will look back at you, and then you can continue the story. Next slide. So as an example, I would say that, for example, somebody had a malignancy lung, and the local doctor took an X-ray, and that showed a shadow. So I will say your X-ray showed something like a shadow, something like a shadow. And to find out what the shadow was, you were referred to the city hospital. So something like a shadow becomes a shadow. The X-ray showed something like a shadow, and to find out what the shadow was, you were referred to the city hospital. In the city hospital, they did a CT scan. They found something like a tumor. And to find out what this tumor was, they did a biopsy. So something like a shadow graduates to shadow, shadow graduates to something like a tumor, and something like a tumor graduates to tumor. And then the biopsy was done, to find out whether it was something like a cancer. And if the patient at this point of says, doctor, do I have cancer? You can just say, I'm sorry, yes. Or you can just nod your head, non-verbal communication. Or if the patient does not say anything, then something they did a biopsy to find out whether it was something like a cancer, and the report came out, and it was indeed cancer. I'm so sorry to tell you this. So it's not that you straight away tell somebody that you have a cancer. You you tell the story from the beginning. You fill in the blanks with pieces of information. Watch the patient, whether the patient is responding, is continuing to look, make eye contact. Then you continue the story. If the patient stops making eye contact, you pause, you wait for the patient to come back to you, look back at you, and then you continue the story. At any point of time, the patient taking a lot of time, not looking at you, then you can ask, should I continue telling you this? If the patient does not speak, does not make eye contact, that means the patient had enough. Or if the patient looks back at you and says, yes, continue, I want to know more, then you continue. Next slide. So this is what I was talking about. And once you have reached a point where either the patient had enough information or you have finished all the information that you have, then be prepared for an emotional reaction. The emotional reaction can be in the form of crying, it can be in the form of an angry outburst, nobody told me about this before, or the person may be just sitting there in stunned silence. Whatever be it, allow that emotion to flow. Give time to the patient. If the patient is crying or getting angry or just sitting in stunned silence, don't say a word, don't do anything, just be there. That is the most important part. Allowing ventilation of emotion is a very crucial part of the procedure of communicating bad news. Next slide. This is the very important message I am leaving with you. Don't do something, just be there. As healthcare professionals, we are not taught this skill. We're always taught what to do. No, we are always doing something, either diagnosing, treating, doing something. We are not taught how to just be there. So it's very important that as a part of your procedure, just like if a surgeon has a bleeding in the abdomen and is not able to tie or cauterize it, the person will put a pressure on that area of bleeding and wait for some time. And that waiting, by putting a pressure bandage and waiting for some time, is part of surgery. Similarly, here, just waiting for some time is very important part of the procedure of communicating bad news. Next slide. And once the emotional reaction has subsided, that is the time when the patient will be in a mental state to listen to you, to listen to a rational conversation. Because when the emotion is high, the rational conversation is not possible. So you have to allow the emotion to be ventilated. Only then you can go to the next phase, that's the closing up phase of then planning what can be done and what cannot be done. And this is after the ventilation of emotion happens, then you can sit and talk about what is possible, what is not possible. And as I've said in the previous session also, learning palliative medical medicine is very empowering, because we never have to say there is nothing more from my side. There's always something to be offered. Even if the disease is in a very advanced stage, no disease focused intervention is possible. There is always something that you can offer to make sure that the patient is comfortable. It's very often that I tell my patient, your disease is advanced, nothing more to be done from the your treating doctor side, but I'll make sure that you do not suffer for as long as you need this care. And many times that is a very, very motivating and encouraging statement for the patient and family. Because very often I have had this response from the patient and family saying, doctor, that is all that I want to hear. what you said gives me a courage. So it's very important to understand there is never a hopeless situation. There is always something to be realistically hoped for. Never give unrealistic hope, always give realistic hope. So once all this discussion is over, then you plan what to do and when to meet next, etc., etc. Whether to continue OP or stay in IP, admit, whatever, or discharge, whatever. That is the last part. Next slide. So this is the thing I was talking about. Always give realistic hope, never give false hope. Next slide. And before you close this procedure, always make sure that they have, whether if they have any more questions to ask or any clarification. And uh, oh, and we talked about closing the interview by leaving the door open, that is giving them a number on which they can contact you. If you don't want to give your personal number, do not give it, but give them some contact number. They should always have some uh, you know uh, some number to contact, either you or your team member. Next slide. Post procedure follow up. If the patient is IP, before you go, you can either visit them in the room and say I just dropped in to see how you're doing. Do you have any questions for me? If you did it as a day procedure, then you can call them in the late evening just to say you can tell them I just called to see how you're doing. If you are busy, then you can delegate this work to somebody in your team. Next slide. So can you go back? So this is where we finish communicating bad news. If you have any questions about this, you can put it in the chat box. Rajlakshmi will help with it, and Sunil and I will try to answer your questions as much as possible. Because time is limited, we will move on to the next topic, which is collusion. Next slide. Collusion is essentially conspiracy of silence. Our usual scenario in the Indian context is the family member comes to meet the doctor uh, before bringing in the patient and would request the doctor saying, please do not tell it to the patient. We have not told the patient about the disease. Now, don't think this happens only with cancer. I've had patients who who have not been told about the disease. The patients with interstitial lung disease, with motor neuron diseases. So these are, the stigma of a disease is there irrespective of what the disease is. The family members tries to hide information from the patient. But this, of course, happens the most in cancer because cancer stigma is very widespread. Next slide. Why are they doing it? The family does it to protect their loved one from harm, and harm in the form of information, and the harmful information that can come from the medical professionals. That is why the family tries to come and collude with us, because they want to protect their loved ones from harm they perceive will come from us. Next slide. So the most important part is not to lecture the family member who's trying to come to collude with us, but it's to acknowledge, to accept that they are afraid. They are afraid we may tell this harmful information, this bad information to the patient. And they may have their beliefs, doesn't matter what their belief is. Do not ridicule their belief. Next slide. Because when you challenge or ridicule their belief, they get more anxious and their defenses only increase. So your chance of managing collusion also becomes all the more harder. So accept that they are scared, accept that they're anxious, accept that they have a belief that if this bad news is told the patient will immediately collapse and die, or the patient will get a heart attack and die, or the patient will commit suicide and die. So they can have any kind of belief, except that people have different kinds of belief. It may not be rational, but they have beliefs. Do not challenge it. So two things you have to accept, that the family member is anxious and afraid, and the family members have certain beliefs. Next slide. So what is to be done? As a first step, you agree to collude. You say, okay, fine. If you don't want me to tell the bad news to your loved one, fine. In addition, I will also ask, so what have you told them? And they will say, okay, I told that you have an ulcer. So I say, okay, shall I also say it's an ulcer? So they, so what happens is immediately their anxiety comes down, and they then feel, they start trusting us, because we have agreed to collude. Their anxiety comes down, they will be more cooperative, and then they will be able to give you information, because when they're so scared, their emotional part of the brain is so active, the rational part of the brain does not work. So even if you're asking simple questions, they, because they're so scared and so anxious, they may not be able to give uh, straightforward answers to our simple questions as to when were the symptoms first noticed, since how long these symptoms are. They may not be able to think properly. It's very important to calm them down, bring down their anxiety levels to very low, just by agreeing to collude. And this is what is the first step. Next step, next slide. And once you have brought the first part, that is agree to collude, then you take care of the patient. Make sure the patient becomes comfortable. Take care of the pain, breathlessness, restlessness, whatever it is. Once you get the patient comfortable physically, the family will start trusting you more and more. And slowly, they will be open to your suggestion. But before that, you have to work with the family, make the patient comfortable, and listen to the family, listen to their concerns, listen to their beliefs, everything. Next slide. Once the family is having trust in you and they start listening to you, earlier you were listening to them, they start listening to you, then you bring in these topics that I talked about, why we should communicate bad news, preventing hospital hopping, doctor shopping, having a chance to finish the life's business, the problems related to barrier between the patient and the family, and the concept of total care. All of these things you can bring in at a later stage, so that the patient's family is now in a better frame of mind to understand these kind of things. Not only are in a better frame of mind, they also trust you, because they have seen how well you are taking care of the patient. It is possible that meanwhile the patient may be pestering you, doctor, what is wrong with me? Doctor, what is wrong with me? And at this point of time, without the family's permission, you cannot communicate bad news to the patient. So you may have to buy some time by saying, I'm still studying the results, I need some more time. While you are buying time with the patient, you try to manage collusion with the family, and hopefully a happy ending will be there, where the family agrees to uh, to the idea of having an honest sharing of information with the patient, and probably they will ask you for your services to facilitate honest sharing. Then you can do it. Next slide. So once you have been invited to share the information with the patient, only then you go on to communicate bad news to the patient. It is possible that your effort at collusion management may not have succeeded and the family is adamant, do not tell it to the patient. Then you have no choice but to listen to them. You can at best provide physical comfort to the patient, and that other problems will continue. But please remember, do not make it your agenda to manage collusion and communicate bad news to the patient. It is your responsibility to talk about these things. It is your responsibility to try to make the family see the rationale behind all of that, but do not push beyond a point. Because if you push for these things, it will seem as if you have an agenda, and then this will create distrust between you and the family, and which can affect in the care of the patient. or the family may feel that you can't be trusted, and they may take the patient away to some other place. So whatever good you could have done for the patient, that also you will not be able to do. So do not push, try to do a gentle job, and it's possible that you may fail. But there is no shame in that. The shame is only in trying, not trying. You try and you failed, there is nothing to be ashamed of. The only shame is if you did not try at all. Next slide. Okay, go back. So this was the last slide on managing collusion. If you have any questions on collusion management, please put it in the chat box, as I mentioned earlier regarding the communicating bad news. Now we are going to the next topic, which is managing anger. Can we have the next slide, please? So anger is a negative emotion. It consumes a lot of energy. Hence, anger is a high energy consuming negative emotion. So the trick is in cutting off the energy supply, and then anger can be controlled very fast. So that is the trick we have to learn, how to cut off the energy supply to the anger. Remember, anger is a form of emotional distress. One emotional distress that you're all familiar with is crying. But anger is just like crying. It's an emotional distress. It is just another form of emotional distress. However, we find easier to handle somebody who is crying than handling somebody who is angry. But if you understand these 2 points, then it becomes very clear that it is stress management. And anger is an emotional stress, uh, it's a negative emotional outcome, and it takes a lot of energy to stay angry, to get angry and to stay angry. So if we cut off the energy supply, we can easily manage anger. And how to do it is the skill. Next slide, please. Most of the anger happens either two ways. One is whether you are ignoring somebody who is getting angry. Can you go back to this previous slide, please? If somebody is angry and you are not minding that person's anger increases. This can happen at the reception, this can happen at the security station, it can happen anywhere. Similarly, if somebody is confronted, it can increase anger. Confrontation in the form of getting into an argument or trying to explain to somebody who is angry, or sometimes if somebody is very angry, even apologizing can make the person more angry. That depends on the intensity of anger. So anything can become a confrontation, an explanation, an excuse, an argument, anything can become a confrontation. Sometimes even an apology can become a confrontation, and that can increase anger. And the second category was ignoring somebody can become anger. So there are two classes of fuels. Fuel means fuel supply. Confrontation can increase anger, and ignoring can increase anger. So if we take care of these two parts, then the energy supply is cut off. Next slide. So how to do that? So do not argue, do not ignore. The simple thing is, if somebody is getting angry, we have to allow that anger to flow in a controlled manner. And for that, you have to use your body language, because if you speak, it can become confrontation. So when somebody is getting very angry, stand in front of that person. Do not sit, because if somebody is angry, that person is unlikely to be sitting and getting angry. Most likely that person will be in a standing position when the person is very, very angry, because there will be so much of adrenaline, the person will not be able to sit. So most of the situation where we see somebody is very angry, that person is usually standing. So when you also stand, you are making your body in the same position as the angry person. And that equality will help facilitate communication. If the person is standing and getting angry, you continue to sit, it will make the person more angry. So you stand, the person is also standing. That means you have created equality. The next important thing is to bend slightly forward, not too much, slightly forward, because slightly bending forward shows respect. And make eye contact, because when you make eye contact, you are showing confidence. So equal position, respectful posture, and a confident standing. So these three things are achieved when you stand, bend a little forward, and make eye contact. So here you are neither confronting nor ignoring. You are respectfully standing and making eye contact. So it is neither confrontation nor ignoring. And this is the trick in allowing the person to facilitate this anger. And in this position, do not speak if the person is getting very angry. That person is, let the anger flow. It allow ventilation of emotion. And once the major severe anger comes down, now the anger is very, mild to moderate, then you ask the person that I want to know more about what you're angry about. Can we sit down and talk? Give this invitation to sit and talk only after lowering the severe anger. And then when the person agrees to sit down, then allow the person to talk some more. So you make sure that this person talks, and the anger flows away accordingly. It is possible that you may not have a solution to why this person is angry. In that case, just listen to that person. Don't give any excuse. Don't offer solution which is not realistic, because then that will make the person more angry. So just listen. If you have a solution to offer which is realistic, this person got angry because of so and so reason, and this can be sorted out by this method, then offer that solution. So if there is something that can be done, do it. If something cannot be done, just listen, continue listening to this person, and in the end, if appropriate, you can offer an apology. If there is no reason to apologize, do not apologize. If you think that even though there is no reason to apologize, but considering the situation, it will be nice to offer an apology from your personal end or on behalf of the department or the institution, you can do it. That's an individual choice. But if there is a need for an apology, make it. If there is no need for an apology, do not make it. If you think you can make an apology just as a ribbon on a present, you can do that also. But that comes only in the end. Any apology comes only in the end when the situation has been resolved, not in the beginning. I hope that part is uh, uh, taken care of. Now remember, this is a technique of managing anger in a clinical environment. However, if you are dealing with a mob which is very angry, then that is a law and order problem. You cannot use this technique in front of a mob. You have to allow people who deal with law and order, the police and security, to take care of that. If you're dealing with somebody under the influence of alcohol or other drugs, where you cannot expect a rational discussion, there also this technique is not to be used. That is again a law and order problem. So this technique works when we are dealing with your day-to-day anger situation in the clinical environment. Next slide. There's a possibility that you are also getting angry. It's not always the patient or the family member gets angry. You can also get angry. And what happens is we don't realize we are getting frustrated and we are getting angry. And sometimes we may just burst out uh, on on our colleagues or our co-workers. It may be a nurse or a physiotherapist or a pharmacist or anybody or the security person. Or sometimes we may burst in anger on our patients and their family also. So none of this is good. So it's very important that be aware that you can also be angry and create a problem for yourself and others. So it's very important that you be aware of it. A simple practical thing that you can do is to have a buddy system. That is, uh, have a colleague who will look after you and you can look after that person. That is the buddy system. It could be a friend or it could be a colleague. The idea is the person who is usually there with you. It could be your uh, ward nurse or it could be anybody, the person who is most likely to be around you. You delegate the job of, you assign this responsibility to that person, that in case your pitch of sound is going, your volume of sound is going high, abnormally high, or you are speaking very harsh language, or you are speaking very sarcastically or angrily, then to inform you, because it is easy to control your anger when you become aware of it in the early stages. So the responsibility of your buddy is to keep tapping you, poking you, and telling you that, hey, you are getting angry. Hey, you are becoming loud. Hey, you are becoming too sarcastic. And that is one good way of controlling your anger. And of course, you have to return the favor also. You have to make sure that you are also helping somebody out in the same way. So we all help each other out in making sure that we are not getting out of control either. It's like a spotter, you know. There's a friend who spots the anger in you and informs you beforehand before it gets out of control. So that will be how to take care of anger inside you. I hope that's the last slide. Is there another slide? Okay, that's it. In case you have any questions related to anger also, please put it in the chat box. Sunil and I will try to answer as much as possible. So thank you. I'll finish there and hand over the discussion back to Sunil.
Thank you, Biju. So if you have any doubts, you can ask now. Anybody?
I think this must be a bit of an information overload. Uh, Communicating bad news, collusion management, and anger, clinical anger management. Too many topics in one short time.
Okay, Dr. Bismi says mostly we have mobs in hospitals to deal with. Necessary information that we never learned about in our medical training.
Yeah, it's true. Before coming into palliative care, I also had no idea. I still remember that Sunil and I were the first batch, and there were two British ladies. One was a nurse, and another was a social worker, who had become full-time communication trainers. And I'm talking about 2004. So when they came and they did uh, a 2-day workshop on communication skills. That was the first exposure to the possibility of communications in healthcare. And I can't agree enough that communication is perhaps the most important part of skill training that we healthcare professionals must have. Uh, and regarding the mob part, I have mentioned it already that you as a healthcare professional, you are not trained, and it is you are not only you are not trained, it is not possible as a healthcare professional to deal with a mob. We are doctors, we are nurses, we are not policemen. We carry stet, we do not carry lathi, we do not carry gun. So it is essentially the responsibility of the law and order mechanism uh, in the hospital and the hospital administration's responsibility to protect all of us.
What is the right time to deliver bad news, Biju?
I'm sorry, I can only hear. I have lost the video part. Yeah, okay, sorry. Yeah, I suddenly found myself after the meeting. When is the right time?
Yeah, yeah.
At the earliest. See, the problem comes when at every stage of the patient's journey, people have not been honest with the patient and the family. So all of this accumulates and all of this has to be conveyed in the end, and mostly by palliative care physicians like us. So if the family physician who first saw the patient had told, I see a shadow in the lung, it could be tuberculosis, it could be fibrosis, it could also be cancer. So it is better you go and get it checked. So that honest sharing of information should start from the first contact. Unfortunately, most of the time, at every level, the honest sharing of information does not happen. So this patient went to the city hospital where specialist had a look. They found CT scan showed a tumor, the biopsy showed a malignancy. So before taking CT scan, they could have said, look, your family doctor has taken this X-ray. It shows a shadow. It could be tuberculosis, it could be fibrosis, it could also be cancer. We are going to do a CT scan to find out what it is, and hopefully we will be able to tell you better. And after getting the CT report, then you can then if the specialist had said, look, this looks more like a tumor, and it is important to get a biopsy done to find out whether it is a okay tumor or a cancer kind of a tumor. That's why it is important to do a biopsy. And that honest sharing information uh, could have led to the next phase, where after a biopsy report comes, where the patient uh, has a proven biopsy proven malignancy. At that point of time, the patient and the family already knows that the story so far, and then it was just a matter of confirming to the patient that the biopsy result did come out as a cancer. Sorry, we'll send you to the cancer doctor. And at every stage, if there had been honest sharing of information, we will not be in this mess that we find ourselves in. So the simple answer to when to tell the bad news, right from the first contact, the first time the patient contacts you, and if you don't know what is going on, you tell them we don't know what's going on. I am asking for an X-ray because I want to know what is going on. I with all the symptoms, I think it could be TB, it could be a fibrosis, it could be a tumor. I want to find out. So it has to be an honest sharing of information. I hope that answers the question.
Uh, I didn't. There is a question, but I couldn't understand it properly. So that was is collusion strictly speaking ethical? Okay, okay, I did get it. And is there a medical legal angle?
Uh, Collusion being ethical. See, um, when we talk about ethics, perhaps the first ethical principle is patient's autonomy that comes in. But please remember, most of these ethics that we learn, patient's autonomy, beneficence, non-maleficence, justice, etc., has to be seen in context. Most of this ethics that we're talking about in the Western concept, where the society accepts individuality and the sacredness of autonomy, this principle is practiced in spirit and letter. In our country, where the concept of individuality is almost alien, it's all about family, it's all about the village, it's collective. One person is not important. The family is important. The khandan, or the you know the collective wish is important. So in our concept, in the oriental concept, individual autonomy is less important socially, even though as medical practitioners we learn it is very important. But our social reality, the context that we live in, is different. So we cannot practice ethics devoid of the ground reality. That is where this conflict comes in, especially when we're dealing with collusion. The conflict comes in, and we have to amicably solve the problem, not by confronting the family by saying it is the patient's right. The patient has autonomy. You have to respect the patient. You can do that, but that will be just theoretical exercise. In reality, the patient will be taken away by the family, and they may even throw a stone at you. So if you really want to do good for the patient and the family, you have to remodel how you are going to approach this ethical dilemma. That is all I'm saying. Be practical, agree to collude in the beginning. The idea is you cannot reach the patient without the family being on your side, because you will only create more trouble for yourself, and you will only create the distance between you and the patient that you want to care for, if the family is not on your side. I hope I that's the best I can answer that. And what was the other thing that you were talking about, Sunil? What was the last question that you said? Something medical legal? One second, I'll also have a look. Is there a medical legal angle? Uh, I don't know the uh, what's the meaning of that question. Is there a medical legal angle?
So probably, Biju, if the doctor is not revealing the diagnosis or prognosis to the patient, can the patient go to the court?
Yeah, possible. I mean, definitely. I know for a fact that in most of the developed countries, where autonomy is sacred, the patient can take you to court for not revealing the diagnosis to him or her first, because in that kind of communities, you can talk to the family only with the permission of the patient. And if you breach that, the patient can take you to court, and the court will definitely be on the side of the patient. I'm not so sure about what will happen in the Indian context if a patient were to go to court and says my autonomy has been breached by this doctor who talked about my disease to my family, who told my wife, who told my children, and did not tell me. I guess the likelihood of this happening is possible, but it will be rare. I also think if it happens, the court might side with the patient and might say that the doctor is indeed guilty of breach of autonomy, because the court will look at the ethical principles, and if that has been violated, the court is likely to. So that is where the medical angle, legal angle comes in. But for practically very unlikely scenario. However, if we are dealing with a disease which is notified by the government that it has to be reported, and that is where a problem comes in. For example, notified disease like HIV or other such infectious diseases, it has to be notified, and then the person has also need to be informed. So that is where you may get in conflict with the family, because then it is a government notification, so it has to be notified, and as a result, to keep the society safe, you may also have to inform the carrier of the disease, the patient, that you have so and so problem, and as a result, you have to undergo so and so precautions as advised by the government. I don't know whether these answers are satisfactory at all, but please feel free to fill up any part, Sunil.
No, I think that's okay. And we will move on to the patient story. Dayalashmi. So today's patient story will be presented by Dr. Rosemary.
Yes. Good evening, everyone. I'm Dr. Rosemary, and I will not be sharing the video because my network is poor. I'm from Nagaland. This is the story of a 65-year-old male diagnosed with non-small cell carcinoma of the lungs with mets to the brain, liver, and diabetes, UTI, and asymptomatic cholelithiasis. The presenting complaint of the patients were headache for 3 weeks, generalized body for 3 days, lower back ache, non-radiating, which he says was like as though it's going to break, and unable to sleep for 3 days and restless for 2 days. The history of the presenting illness is that patient was apparently well till 3 weeks back when he developed headache, which was dull aching, deep-seated and dull aching localized to the frontal and occipital area and increased intensity for the past 3 days associated with vomiting. He was evaluated outside elsewhere here in our local hospital, and preliminary investigations were done, at the time of admission, chest X-ray, CT scan of the brain, and since they found that there is some problem in the brain, patient was referred to our hospital, so saying that there is some kind of lesion in the lung. They have also done CT scan of the chest. On examination, the patient's vitals were stable, though he had headache with vomiting for the past 3 days. Sensorium was normal. Other vital systemic examinations were grossly intact. He had restlessness because of the wherein he was not able to lie down in one position. He was just rolling because of the intractable headache and the body pain. Next slide, please. So the treatment and the investigations given were like a scan of the brain, which was done outside, short multifocal rounded hyperintense axial lesions with moderate perilegional edema at the gray-white matter junction, the right frontal lobe, the left parieto-temporal and right parieto-occipital without significant mass effect. Unfortunately, the CT scan the chest, which was done outside, was missing from the patient's file, where we tried searching, but it could not be found. Only the film was there, which I could not project it here. MRI of the brain shows confirmed the findings of the brain CT scan, and which was likely to represent hemorrhagic brain metastasis marked perilesional edema without midline shift. Further investigations of the USG abdomen showed ill-defined hypoechoic lesions in the right lobe of the liver with mildly thickened gallbladder with cholelithiasis and well-defined well-defined hypointension nodule in the right retroperitoneal area, query-metastatic nodule. CT scan of the abdomen confirmed the findings. X-ray of the chest showed opacity in the left middle lobe, and CT-guided lung biopsy was done, which showed just suggestive of non-small cell carcinoma. PET scan could not be done here because we are not available here in our setting. The other investigations showed urine suggestive of urinary tract infection, and hemoglobin was normal, total counts were raised, liver function and kidney function were normal. He was found to have sugar, HbA1c of 9.3. The psychosocial aspect of the patient is that he comes from a good, well-knit family with 3 sons, who are 2 of them are government employees. He himself is a retired government employee, enjoying a social support. And after the retirement, he is working as a leader of a local church, wherein he is the major decision maker in the church. And because of all his background, his employment, and currently leadership involvement, he enjoys a good social status. But the local church members misses him and the advice that they get from him. So the medication where the patient, after initial approach to the hospital for his symptoms, he stayed back at home for two more weeks, because he will be all right with the painkillers, and he was taking Dol at home. But after 3 days, he came to us when the symptoms were worsening. In the past 3 days, he came to us, and we started him on paracetamol, and injection mannitol was given, which was gradually tapered and stopped. Tablet tramadol was started on him, but he could not tolerate it. He said severe nausea and vomiting, and so it was stopped. And so it was morphine. Initially, he refused the morphine medication because he said he will be all right. But then since the pain was not getting relief, the pain score was 7 by 10. It was started on morphine, and on the 3rd day of the admission, since it was found no significant improvement, tablet amitriptyline was given to him, following which symptoms resolved significantly. For the UTI, initially injection ceftriaxone was given, and then changed later into culture-specific meropenem. And then after about 5 days, again, patients started complaining of severe body pain, which he could not exactly say what was the type of pain, where it was generalized body pain and back pain. So we did not do any bone scan or X-ray of clinically suspecting to be mets to the bone and bone-related pain. He was given zoledronic acid, 4 mg stat was given, and for his sugar monitoring, and it was done. It was started, later changed to mixed start, which and then patient was symptomically better again. So on the 2nd day of the admission, patient patients' attenders were called, and uh, the disease was discussed with the patient's sons. And then they said, like, in the other hospital, they were told that there is some problem in the brain, so they are being referred to another hospital. But since they exactly did not know what was the cause of the problem, and the patient was slightly better at home, they stayed back 2 weeks at home, and then they came back to us, And so the illness, each illness of the patient was listed out, and we initially asked them would what they think of the illness was, and so they have no idea. And so we started explaining to them about the findings we had with the investigations, and gradually the disease was explained to them, and the disease, each symptoms were listed out, and we explained to them our plan of treatment, and we also asked them what their goal was after explaining the disease condition to them. And then they said, like, and they just want symptomatic relief. They don't want to go for any treatment for the cancer because it is already advanced and metastasized. So the patients agreed to, the patient's sons accepted the nature of the disease and progression of the cancer, but they were like, at least you can relieve the symptoms of my father. So that much, you cannot cure the cancer, but you can at least relieve the pain. So we told him that we will do our best. And so we were treating him with the previous medications, which I have mentioned. And about a week later, the patient was almost like 95% symptom free, except for the generalized weakness and mild headache. And so after a week, he was with us like that for about a week. He was okay, doing well, but and then he was planned for discharge, but the attendants, the sons and the wife, wanted him to stay on in the hospital for a few more days till he gets completely all right, or he regains his energy to be independent and be walking, doing his normal, almost normal work. So for about a week, he stayed with us like that. And then when we were planning to discharge him, just one day prior to the discharge, patient started complaining of, again, restlessness, insomnia, body pain, headache was increasing, and he was refusing to take medications. He refused to take medications mainly because he was refusing the morphine, and without our knowledge, the attendants, they crushed the morphine and gave to him, and then he was so bitter that he refused to take the morphine also. And so when the symptoms of restlessness and insomnia, body pain recurred, we re-investigated him for any treatable causes like infections, and they were all normal. But the sensorium deteriorated by the third day, and at this time we discussed again the treatment plan for the patient and gave them option for palliative radiotherapy. And they said, like, they will discuss and tell us. And so on the third day, when the patient's sensorium did not improve, the patient's relatives agreed for palliative radiotherapy, and 3 doses of radiation was given to the brain. And there was no significant, very satisfactory improvement, but there was slight improvement. But patients, of course, they were not aggressive, but they were not very much satisfied with the response that the patient is having with the treatment. And so they stayed on for a few days, and radiation was stopped after 3 doses because the patient's attenders decided not to give him anymore because the patient is no more improving. So they wanted us to relieve his other symptoms, but we couldn't assess the pain at this time because he was already in altered sensorium, and so we were not able to use our pain medications. So finally, they stayed on with us for about like a month. And on the day before the Christmas day, they got discharged. At the time of discharge, patient was slightly better, though a little restless. He was still in having little headache, and but he was responding to communication. So this is the story of our 65-year-old man who came with advanced cancer. Next slide. So the main concern of the patient and the patient, more of the patient attender was pain relief, and they wanted him to be independent. They wanted him to be like taking decision and making decision for their local church. They want him to be at least moving around and doing his activities by himself. And more importantly, they don't want to see him rolling on the bed with pain or complaining about headaches. So they wanted him to be pain-free. Here is the summary of a 65-year-old man who was newly diagnosed to be having diabetes with urinary tract infection and non-small cell cancer of the lung with the mets to liver and brain, with intractable headache and generalized body pain. So my discussion points here are like what best could have been done for his restlessness and headache. Of course, he was at times he was not compliant to the drugs because he he used to miss out his morphine when we go for rounds. The doses of the morphines used to be missed out. He was not taking regularly. And in this scenario, how do we explain to the patient's relatives about our inability to meet their expectation, the expectation of complete pain relief and to be fully independent again? How do we prepare the patient and his relatives to accept the reality of the terminal stage of the illness? Because I feel like though they were not aggressive or they showed us like they understood about the illness, they were not very much by their expectation from us to be completely pain-free. I felt like they have not really understood about the nature of the illness. So these are the points which I would like to discuss. Thank you.
Thank you, Dr. Rosemary. I think we doesn't have much time, so Biju, can we discuss the last two because it is related to communication? So can you give your comments?
Uh, I guess I because I was not there in that situation, so it's very hard to make a comment on what was the relatives' expectation uh, per se, because if the relatives were expecting better pain control, and then what was the barrier to better pain control? Was it the patient who was refusing morphine? Was it the family which was not adequately informed about the dosing, including the breakthrough rescue doses for the breakthrough pain? What exactly were the barriers? And if once we understand what the barriers were, then we can do many things to get over those barriers to pain management. If the patient had some fears about morphine, uh, a good counseling regarding morphine could take care of that. If it was an inability to understand when it should be given, and apart from regular doses, how rescue doses should be given, how many times a rescue dose can be given. So all of these things is something that we face on a day-to-day basis, and the simple solution is to find out what they understand about morphine, about their dosing, etc. And once their knowledge improves and their compliance improves, the pain management hopefully will get better. It's also possibility that we are probably dealing with a kind of pain which is more difficult to manage, and maybe some expertise is required. I don't know what kind of expertise is available where this patient was. So that is again something I can't comment upon. So this is what would be my first part as far as this how to manage the patient's relatives expectation was concerned. Regarding how do we prepare the patient and its relatives to accept the reality of the terminal stage of illness, I guess today's session might have thrown some light on that.
Yes, sir.
We have to find out their insight, the patient and the family's insight, and their concerns, and then follow up on that. That would be the short answer to that.
Yes, yes, sir. Thank you very much, sir. It was very helpful for me today's class.
Thank you, thank you. Excellent presentation, though. I must commend you on that. Very, very crisp, very comprehensive, and very well presented. Keep it up.
Thank you, sir.
Uh, I think if we have optimized all the treatment and still we are unable to give them proper control of symptoms or something that they expect, then we can tell them we have tried our best and this is what we can achieve. But if you want any other consultation outside this hospital, we are okay with that. You can take him to a consultant and get a consultation. But if at any point of time, if you feel that no, you are not getting proper care, come back. We are here to receive him. So that can be offered to them. If you think you have optimized all the care for the patient. So a second or a referral to somebody else can be done if they want that.
Yes, sir.
Uh,
We had palliative doctor, but he left our hospital, and we are finding we are
yeah.
having issue with palliative patients right now in our hospital, especially the
Okay.
pain management. So
Yeah. So what best could have been done for the restlessness and headache? Biju?
at
Yeah.
headache which was intractable, he could not say where exactly, what type of headache. So we
Yeah.
were
Yeah.
helpless, like.
Hmm.
Was he on? I understand that he had brain meds.
Yes, sir, yes, sir. He
Yeah.
had brain meds.
So what was being? I saw there was a mannitol which was given for some time,
Yes, sir,
and
yes, sir.
apparently
It was
that gave some
Morphine,
relief.
amitriptyline.
that gave him relief. Injection mannitol gave him relief, and then
Yeah.
when we stopped again, his headache recurred. So we in fact, after about a week, when he complained again of headache, we restarted him on mannitol. And then gradually we tapered down and we gave we started him on mannitol. In the second time, it didn't help much.
Right. Mannitol is usually used for a very short duration,
Yes.
ideally for about 3 days.
Yes.
Continued use does not help.
Yeah.
Sometimes it causes rebound
Yeah.
edema
Yes.
and worsening of symptoms. So maybe I would have used steroid and continued the person on oral steroids
Oh,
at
okay.
the time of discharge.
Okay. Okay.
If the patient is diabetic, then of course the
Yeah.
OHA or the insulin would have to be titrated to control the hyperglycemia because of steroid.
Yes, sir. Yes, sir. Yeah.
Uh, any other suggestion that comes to your mind, Sunil?
No, Biju, I completely agree with you because in patients with brain metastasis, usually blood-brain barrier is not intact. And in such situation, mannitol may not be much helpful, and
Okay.
steroids would be better in such situation. So dexamethasone, which is less water and sodium retention, steroid which can be used and maybe if the patient has a good relief with steroid, you sometime you need to continue the patient on steroids for lifetime. um, and you can actually titrate the dose of steroid dexamethasone to find out the lowest dose possible.
All right, sir.
And maybe for restlessness, if he's so much agitated in such situation, you may also use an antipsychotic,
Okay.
maybe low dose haloperidol or quetiapine, which might be helpful.
Yes, sir. Thank you, sir.
Anybody else want to comment on these three questions? Anybody?
Just one point which is little not related to what we were discussing. I saw some tramadol in that
Yes, sir.
Yeah.
thing. So when
Yeah.
we are dealing with a situation, because tramadol has a problem, it reduces the seizure threshold. So if you're
Okay.
dealing with a patient who has a history of seizure, past history of seizure, or a medical condition which potentially can lead to seizure, in this case,
Yes, sir.
intracranial lesion, there
Yes,
it
sir.
is preferable, it is important to avoid tramadol because we may end up precipitating a seizure. Usually happens with higher doses, not much with lower doses, but better to, I wouldn't use tramadol in this situation. Morphine, absolutely fine, no problem. But tramadol, I would avoid. That's just a side point that I thought I should bring in.
Thank you very much, sir.
I think if there are no more comments, we can wind up the session. Thank you, Biju, for being with us for 2 days
My pleasure,
for having
absolutely.
this communication